Hello there and welcome. My name is Dr. Lopez, and today we are going to discuss substance use disorder, more specifically, alcohol use disorder and CIWA, right? Again, alcohol use disorders is very serious. When you compare someone with substance use disorder, opioids, when they go in withdrawal, it's terrifying. They're just hating life. Not that alcohol withdrawals are much better, but the difference is that alcohol withdrawal can kill the patient. The patients can go into common hallucinations, seizures, and many other side symptoms of alcohol withdrawal. So it's important that we understand when to give a medication, when the patient it is at the highest risk, and which medication to give. So let's go ahead and discuss some components of the CIWA scales and when to act during treatment. So this is our roadmap, substance use disorder assessment 2. This is where regarding CIWA scales. So only for alcohol. Do not confuse CIWA scales with COWS. COWS for opioid use disorders. CIWA is for alcohol use disorders. Okay. So here we have it, the CIWA scale. What is CIWA? That's the Clinical Institute Withdrawal Assessment. All right. We are assessing for alcohol withdrawals. We want to determine which medication to give during withdrawals or detox. In the CIWA scales, you start treatment as needed when the score reaches 8 or more. Starts the treatment PRN only when the score is 8 or more. To remember this, thinking an 8-glass fate, okay, for a score of 8 or more. Now, when it comes to the next level, between 8 all the way to 14, is PRN. 15 plus now is the scheduled medication and PRN. It's important to know when to do PRN alone, when to do PRN plus a schedule. Great. So the third important point that I really want you to be aware of is the use of Valium and Ativan. Valium or Ativan or other benzos can be used as well. But most I've seen it as diazepam, which is your Valium, and your Ativan, which is your lorazepam, right? Now, questions may ask, which one of the two would you use? And then it depends. Does the patient have a liver disorder, perhaps like hepatitis? If so, your drug of choice is Ativan. Don't forget. And the reason is very, very simple because Ativan has a shorter half-life. So the two medications she uses is Ativan or Valium, right? And if the patient has a liver disorder or hepatitis, you need to pick the one with a shorter half-life. Mnemonic, liver lover, lorazepam, LLL. Okay? So if the patient wants to stop alcohol intake, right? There are three medications that are FDA approved, and they are called the DAN. The D for disulfiram, which is anti-abuse, nasty medication, by the way. If you take it, if the patient takes it and consume alcohol, they will never forget. It's very, very unpleasant. Now, a composite and naltrexone are the two most used medications for alcohol use disorders. Why? Well, simply because they have shown to reduce alcohol consumption and increase abstinency. So if the patient have a relapse, even though they would feel less of a high, they would be more inclined to stay sober next time and increase abstinence time compared to other medications. So the two medications that do that is a compensating naltrexone, disulfiram is a nasty medication also known as alcohol uh, uh, alcohol a prevention, right? A prevention for alcohol because of the NAST side effects. So remember, liver love Ativan, right? Because of a shorter half-life. So if it's important to know that when are the patient at the higher risks? And these are sometimes called stages. These are sometimes called by the hour. So here we have a 6 to 12 hours. Well, before that, let me go ahead and discuss a case here. So I had a patient that was drinking about what is that 4 liters of alcohol, hard liquor, per week. Right, that's a lot of alcohol. So he came to me, and I did an assessment, and definitely he needed to be in treatment, right? And his vitals was elevated, his heart rate was elevated, his blood pressure was elevated, he was sweating, he had the chills, and he had not had a drink in the past 2 days, almost 2 days. I had not been quite 2 days yet. And he said he never feels alcohol withdrawals. And then I was like, how is that even possible? Well, it brings back to the fact that most severe symptoms really occur after 48 hours, and he had not been without alcohol ever for 48 hours, right? He usually had a drink in the morning, did not want to cut back. So that is the underlining that you have to discuss with your patients why you have not had symptoms about alcohol withdrawals. It was simple. He was drinking in the mornings, but having a whole bottle of whiskey on Wednesday night and the whole body Friday, Saturday, and Sunday, right? So he was really never without alcohol for more than a 24 hours period. But as you see here, these are the 3 stages categorized by the hours, right? So those symptoms includes unclear thinking, headaches, dilated pupils, nausea, vomiting, and loss of appetite, minor hand tremors, right? If they are very coarse, very shaky, this is more dangerous, right? So they are in a closer dangers or more close to a seizure disorder. So unusual lack of energy, I see that very often, and so forth. So now on stage 3 here, the graphic it really says hallucination in seizure. I usually in practice only see this on stage 3 after 48 hours. Now it's very well known a symptom of alcohol use disorders, those tactile hallucinations, right? They feel like something is crawling behind their skin. So this is something to be watch out for and ask what kind of hallucinations they're having. So regardless, the point is 12 to 48 hours, they would have a more severe withdrawal symptoms than the initial 12 hours. That would include mental confusion, increased vital signs, that i.e. Blood pressure, heart rate with irregular beats, right? Difficult seizures and decimation, um, difficult breathing and seizures, right? Now, when they reach the 48 hours period, it's past the 48 hours period. Now they are in the danger zone, really more severe symptoms. They would have a higher heartbeat, excessive sweating, fevers, agitation, and disorientation, right? And that after the 70 to 48 hours, they would be more so over the hump, and the symptoms should decrease over time for the next 2 to 3 weeks. Okay, so here are a few things to consider that we discussed. CIWA is for alcohol withdrawal scales. It kind of it's the score really determines the threshold for treatment initiation, right? As we mentioned, if it's 8 or more, it is PRN only. When the patient hits 15, you have to give PRN and schedule medication. We give a benzodiazepine. Two medications that are often prescribed are diazepam, which is a Valium, or lorazepam. If the patient has a liver disorder, you give lorazepam, liver love lorazepam, because it has a shorter half-life. The three medications used for alcohol use disorders and their benefit, as we discussed. Do you remember which are the three? Okay. Uh, let's see what else. Okay. So checking on learning, which patient has the highest risk factor for alcohol withdrawal? A, patient with score of 6. B, CIWA score of 12 with hepatitis. Or C, CIWA score of 18. Or D, alcohol consumption reduced by naltrexone. Okay, which patient would be at the most risk for alcohol withdrawal? And that is C18, right? The patient with the higher CIWA score is always at the highest risk, right? So, for example, if we looked at the patient A, it doesn't quite meet criteria for PRNs. PRNs are A plus. If we look at patient B, it meets criteria for PRN, and you want to use Ativan lorazepam because the patient has hepatitis. Patient C, you need to use Ativan and a schedule medication, right? So you do PRN plus schedule, all right? And patient D, alcohol consumption reduced by naltrexone. It doesn't give you much of the information there, all right? So checking on learning. Let's see here what we have. So let me increase the screen here. What is the appropriate medication administration timeline for a patient experiencing alcohol withdrawal as per CIWA protocol? Okay, patient A, PRN medication started at the score of 8 or higher. Scheduled medication can be given at the score of 15. And the patient should be assessed every 2 hours by the nurse practitioner. B, start the PRN medication at 5, schedule medications at the score of 10, and assess the patient every 4 hours. C, begin PRN medication score of 10, initiate schedule medication at the score of 20, evaluate the patient every 3 hours. Or D, administer PRN medication at the score of 6 or more, begin schedule medication at the score of 12, and assess the patient every hour. Well, this one is a given. I've been happy on this the whole time, and I hope you got this one right. And the answer is A, right? CIWA score of 15 or higher requires a PRN medication. The two choices, well, there are several choices. Benzodiazepines are usually the recommended. Out of those benzos, Ativan is the preferred for patients who with liver diseases or hepatitis because of its shorter half-life. Okay? So easy peasy, don't lose those points. Why do we care so much about alcohol use disorders, right? Because the withdrawal it kills has a high mortality rate. So what are the symptoms? Again, nausea and vomiting, tremors, paradoxal sweat, that means night sweat, tactile disturbance, auditory disturbance as well, headaches, anxiety, agitation, and altered mental status. You need to know your symptoms of an alcohol use disorder. And that's it. This was a wrap. Easy peasy points that you will get on your board. My name is Dr. Lopez, and I can't wait to see you become PMHNP board certified. I'll see you on our next training.